Okay. Good morning, everyone. Good morning. I'm not Dr. Temple. Welcome to TED Talk. Dr. Temple is a licensed clinical psychologist, a fellowship-trained neuropsychologist, and a board-certified sports psychologist. He has over 15 years of experience in the rehabilitation field, treating children to senior citizens and military personnel with traumatic brain injuries of all severities. Dr. Temple specializes in the assessment, treatment, and management of many disorders, including ADHD, PTSD, concussions, learning disorders, emotional disabilities, and dementia. He also utilizes scientifically sound methods to assist athletes in improving their performance. He earned a Ph.D. in clinical psychology from the University of Alabama-Birmingham. He completed a clinical internship at the Medical University of South Carolina and a postdoctoral fellowship at Brown Medical School. Please welcome Dr. Temple.
Thank you and good morning. My talk today is going to be on, as you can see, on sort of mood and behavior issues that arise with pediatric brain injury. And admittedly, there was much more I would love to share with you this morning than the 45 minutes will allow, so a little bit will be a kind of a smorgasbord, if you will. And if you all have any questions, if anything doesn't make sense, if there's anything you want to know more about, ask me a question, raise your hand, or I'll stick around afterwards to answer those questions. We're going to kind of cover a lot of ground today because there's, as you can imagine, a lot of ground to cover. If you're here in this room to listen to this, you probably already know that. It's a pretty complex topic. I'm a clinical psychologist, as you heard. I practice in the South Austin area. I do a lot of traveling kind of all over Texas for various things, consult with rehabilitation facilities all the way from Lubbock to San Antonio and here in Austin. So I get around quite a bit and do a lot of other things as well. So, without further ado, we'll talk about brain injury and mood behavior issues. So, in my work, I kind of got this quote off of somewhere else, but it really does make sense. When folks are dealing with a brain injury, either their own or their child's brain injury, among the most complicated and difficult issues to deal with are these mood and behavioral issues. It's things that I've noticed myself as a practitioner, and also from what I've heard from loved ones, parents, caregivers, that these are the ones that really cause a lot of angst, are confusing, are difficult to deal with, and just cause a lot of day-to-day disruption. And again, there are many more of these, so there may be one that you were hoping I would cover that I didn't. Again, see me afterward, but there was only so much. But among them are things like depression, anxiety, apathy or poor initiation, which is very difficult to deal with sometimes. Physical and verbal aggression, which could come up. If you were in the last talk, you heard about those frontal lobes that inhibit behaviors, and I think on a weekly basis we all have that urge. I don't know if it was dated now. I haven't seen it in a while. There's a T-shirt or a bumper sticker that said something like, self-control is the ability to not choke somebody who desperately deserves to be choked. So we're kind of faced with those either on the road in Austin or wherever we are, but sort of, and sometimes those inhibitions are released when someone has a brain injury, especially a young child who may not have those developed fully to begin with. And then sort of just your run-of-the-mill non-compliance with expectations, which could be frustrating. And then something which, sort of surprised myself that I would bring up in this presentation, but substance abuse. And you think, okay, we're talking about pediatric brain injury, not adults. I do spend a good bit of my time working with adults, but I do a lot of work with kids with concussions. And by kids, I mean everything from 8, 9 years old all the way up to 16, 17. And even once you start crossing the 13, 14-year-old barrier, you start to run into substance abuse issues. And we'll talk about that a little bit. Again, it amazes me. I grew up in Chicago, so I wasn't necessarily sheltered, but I guess in other ways I was, because I'm not sure I even knew how to find that stuff when I was 13 or 14 years old. But it is a problem that seems to crop up related to brain injury, and it kind of goes throughout the lifespan. So we'll talk about that as well. So a little word about kind of the way we categorize these things, psychiatric or psychological diagnoses. Now, On my bookshelf, there's a purple covered book that's about yay thick called the DSM. You've probably heard of it. That has every psychiatric, psychological diagnosis that we have right now. Interestingly, when the first version, we're on the fourth, fifth, I can't look at the cover now, I think the fifth. The first version was like a pamphlet. It was about that thick, and then it kept getting thicker and thicker and thicker and thicker. So now it's a good 800 pages. And again, it has every diagnosis, And when I see folks, parents will come into me and say, I want to know if my child has autism. I want to know if my child has ADHD. I want to know if my child is depressed, is anxious. And what I always say to them, especially with things when you start getting into the domains of things like ADHD and autism, see, okay, I can tell you, I can make that diagnosis or exclude that diagnosis one way or another. But if I just stopped there, you would be bitterly disappointed with the outcome and how helpful that information was to you. Because that's only the starting point, and it's really just barely the starting point. I'm often jealous of physicians, neurologists, neurosurgeons. They've got it easy. They want to know, someone comes into them, they say, do I have cancer? I say, okay, let's take some cells out of you. We know what cancer cells look like. We know what non-cancer cells look like. It's more of a clear-cut kind of thing. It's probably not quite that easy. I didn't study oncology, so I don't know. You go into the ER because you've hit your head really hard. Do I have anything wrong up there? They could do a CT and say, yep, see that spot? That's a bruise on your brain, or that's bleeding on your brain. It's really fairly clear-cut as to these diagnoses. Diabetes, jab a needle in your arm, take out some blood, how much sugar is there, how much insulin is there, tells you everything you need to know. Psychiatric diagnoses are not like that. The way psychiatric diagnoses work is they've kind of come up with behaviors that kind of hang together. They've put the symptoms together, and they give it a name. They give it the name autism. They give it the name ADHD. They give it the name depression. Interestingly, though, if you look at these diagnostic criteria, take depression, for example. There's categories. You need to meet 2 out of 6 in category A and 3 out of 6 in category B and whatever. So this person could be depressed, this person could be depressed, and I could be depressed, and we could have very few symptoms in common, where it's all called depression, but it presents and it looks very differently, and actually we share very few symptoms in common. It's even more the case, I know we're talking about brain injury, not autism, but it's just one that keeps coming to mind. Back, in the DSM-4, they decided to break it out a little bit, and there's autism, and then you may have heard of the term Asperger's disorder, which is in one way is kind of a mild autism, but it's different in a lot of ways. And then in the DSM, they just decided to clump it all together again. So now you have an autism spectrum disorder, which can range anywhere from a child who's completely nonverbal, rocking in the corner, non-communicative, non-participatory, all the way to a person who has average IQ and just some social problems. That's all under the same rubric. So you want to know, and to take it a step further, it's called an autism spectrum disorder, which means there's a spectrum. You know what that means? We're all on it. Yeah. You're on the spectrum, you're on the spectrum, I'm on this, we're all on the spectrum. Because we're all on it somewhere. Again, most of us are probably pretty far down the spectrum, but if it's a spectrum, it means almost by definition that we're all on it somewhere. So again, not terribly useful. It's a good starting point, but then you need to go way beyond that. So I'm going to try and talk about these things today in a number of different ways, and talk about more what causes the problems, and that being kind of the kicking off point of how you deal with them. Another thing you learn very early on in anything where you're dealing with people is that you cannot make the assumption that kids are just little adults. Well, okay, well, I'm an adult psychologist, I want to deal with kids, so I'll just stoop down a little and talk slow. It doesn't work that way. Or, maybe if they have depression, maybe they need only 2 symptoms instead of 5 because they're little, and it doesn't work that way. So kids are qualitatively different than adults. And when you throw in the heterogeneity that brain injury brings, it's even more the case. So that's important. A saying that I heard when I started my brain injury career, again with adults in Galveston, Texas, Dr. Brent Mazzella, who's a neurologist from Chicago, just a great, great guy. And he had a saying, and he said, well, you know, he said in his Chicago accent, I'm from Chicago too, so I have kind of a kinship to the guy. He said, if you've seen one brain injury, you've seen one brain injury. They all present so differently across the lifespan, and even within a lifespan from one individual to the next, that you really do need to take a very individualized approach in figuring out what's going on. You can't just say, oh yeah, okay, I know exactly what that is, and I know exactly how to treat it. It doesn't work that way. All right, so we're going to start out with depression. We'll get this one out of the way because it's depressing. Again, like I said before, a very heterogeneous diagnosis. There's tons of criteria, and you only need to meet a few of them to meet the criteria for depression. And there's a bunch of different depressions. There's major depressive disorder, there's dysthymia. And the other neat and interesting thing that the DSM did was, you know, okay, do you have major depressive disorder? No. Do you have dysthymia? No. Do you have this? Well, then there's depressive disorder not otherwise specified. So there's these garbage can diagnoses where it's like, I don't know what the heck it is, but it looks like depression, it sounds like depression, it smells like depression, so we'll just give it this thing. So there's variability in presentation. In the literature, it sort of makes the distinction, you know, in the last presentation you heard about the role of our frontal lobes, which is very important with these mood disorders as well, is that when a child has depression following a brain injury, sort of what's causing it, and that's very important in trying to figure out how you treat it. Is it actual neuronal disruption, that because the child hit their head so hard that the neurochemicals, the neurotransmitters are messed up, they're not getting enough serotonin, not getting enough dopamine? Is it that? Or is it situational? Is it the fact that they're not in school anymore with their peers, they know they're different than they were before, they've been kind of taken out of their life activities, and we're going to talk about that at sort of the end of this talk. Is that what's causing it? In a recent review that I read, it suggests that most often it's the second of those. It's the fact that not so much the neuronal disruption, but it's more the life interference, how the person's life has changed, the child's life has changed, and the things they're no longer able to participate in that produces that depressive syndrome. And that really ranges, I've seen that anywhere from concussions that have more kind of transient kind of effects, all the way up to major severe head injuries. And you know, when you think about depression, you think about somebody crying and being sad and doing that. Well, again, it presents differently, qualitatively differently in a child, and often you'll see more irritability, anger, aggression rather than the sadness. But that means you can't have the sadness, but sometimes a depressed child will look more angry than they do depressed in the way, kind of colloquially, we think of it. And just to kind of say, well, is it the brain injury, or is it something else? We do see depression more in a child with a brain injury than an uninjured child. And also, kind of a way of comparing, is it just the injury? Would it matter whether it was a broken ankle or a broken brain? Well, it is more common in brain injury than it is in orthopedic injuries and things like that. And as the child gets older, kind of the prevalence of an incidence of depression after brain injury increases as well. So what do we do about it? That's a good question that could probably cover the rest of the 45 minutes, so I'm not going to do that. So there's pharmacological treatments that are sometimes helpful. SSRI medications are helpful. There's some literature to actually suggest, and it's mixed. Every time a new study comes out, it goes back one way or the other, that the SSRI medications, the selective serotonin reuptake inhibitors, the things like Prozac and that you've heard of, they not only help with the depression, but they actually promote positive neuroplasticity, that actually create growth of new connections in your brain. Again, that's a little bit mixed, but there is some support for that. So again, that's another reason to consider that kind of medication. And then where I spend most of my day, because I don't have a prescription pad, is in terms of psychotherapy and other kinds of treatment. And there's different ways that you can do psychotherapy. And when you think of psychotherapy, you might think of someone laying on a couch with a person with a beard, writing down things behind their head. That's one kind. We don't really do that all that much anymore. We surely don't do it with kids. But there's supportive psychotherapy, just kind of, what do you need, kind of just processing the whole issue, providing support, an ear to listen, that kind of thing. Then kind of sort of on the other end of the spectrum in terms of structure is cognitive behavioral therapy, which is more looking at an individual's cognitions, what kind of assumptions they have about the world, about themselves, and sort of challenging those cognitions and those assumptions to the extent that they're not helpful or useful or even accurate. And what we know about these two things, because again, I'll have folks come into my office and say, I want you to fix my depression, this is brain injury or not, but I'm not taking pills. And then there's other people that are fairly open to it. What I say to both of those people is, you know what, cool, I don't prescribe pills, so you're in the right place, regardless. However, I really believe in neuroplasticity to its core. I think it's real, and the more we understand and learn it, the better we're going to do. But if things are really bad in terms of depression, it just makes it that much harder. I say that depression is a mean and cruel and shrewd opponent. Because what I will tell you as a psychologist, well, you need to get back to life. You need to get out of your house. You need to get out of your bed. You need to find the energy to go do the things that you love to do and get back participating. And depression is there saying, yeah, I'm not going to let you do it. I'm not going to give you the energy to do it, first of all. If you do manage to kind of jump over the wall and go and do it anyway, I'm not going to let you enjoy it, at least not initially. So it's very shrewd, and sometimes the medication can sort of help get you over that hump. But then after that, it's these things, the psychotherapy, the work that you have to do that's really going to get you by. Okay, anxiety. Spend a lot of time working with folks with anxiety after brain injuries, as well as the work I do with athletes. It's a very, very common diagnosis and ailment that folks have. Also, I can just keep putting this down for everything. There's a bunch of different kinds of anxiety. There's generalized anxiety, which is just kind of, I can't really figure out what it is. It's not necessarily heights or snakes or people, it's just all of a sudden my body just does what it does and I become anxious. There's social anxiety that seems to be more related to being nervous about being around other people, a fear of being judged, and things like that. Specific phobias that could crop up either as a result of the accident, maybe might be related to the accident or not. And then, post-traumatic stress disorder, which is something that could come up particularly if the child remembers the accident or remembers some component of it that sort of triggers an anxiety reaction more specifically to whatever that stimulus was. Or it could be the hospital. I talked to somebody just the other day. My wife does something called destination imagination, where the kids have to do these projects and everything. There's one really sharp little boy that's in the group. And I just heard a story just last night where he was, in the hospital, and unfortunately he was there to kind of see his uncle at the end of his life. And this kid is now absolutely freaked out about hospitals and everything, that to the point where in the destination imagination, they could do a medical mysteries component of it. And he's like, nope, not doing anything that has anything to do with hospitals. I'm done, I'm out. So PTSD is fairly common.